Medicare LCD criteria for renal disease require that the patient is not pursuing dialysis or renal transplant, and that laboratory values reflect end-stage renal failure, including a creatinine clearance below 10 cc per minute, or below 15 cc per minute for diabetic patients, and a serum creatinine level greater than 8.0 mg per deciliter, or greater than 6.0 mg per deciliter for diabetics. These findings together demonstrate severe, irreversible renal impairment consistent with hospice eligibility. Supporting documentation for chronic renal failure should describe clinical signs of advanced uremia, such as elevated BUN accompanied by nausea, vomiting, or confusion, along with oliguria producing less than 400 cc of urine in 24 hours. It should also note complications like intractable hyperkalemia with potassium levels above 7.0, uremic pericarditis, hepatorenal syndrome, or intractable fluid overload that does not respond to medical treatment. Together, these findings demonstrate severe, irreversible renal decline consistent with end-stage disease. Supporting documentation for acute renal failure should highlight serious coexisting conditions that worsen prognosis, such as the need for mechanical ventilation, the presence of malignancy, or underlying chronic lung disease. It should also note significant comorbidities like advanced cardiac disease or advanced liver disease, as these conditions compound renal decline and indicate a critically ill patient with limited potential for recovery. Key documentation for renal hospice eligibility should include a clear statement that the patient has made an informed decision to decline dialysis, along with recent laboratory values such as creatinine clearance and serum creatinine to demonstrate the severity of renal impairment. The record should also describe uremia symptoms, note whether the patient has diabetes since thresholds differ for diabetic patients, and include 24-hour urine output when available to further support the presence of advanced renal failure. The patient is a 78-year-old male with long-standing diabetic nephropathy and a 25-year history of type 2 diabetes. After thorough discussions with his family, nephrologist, and primary care provider, he has chosen to decline dialysis, expressing a clear preference to prioritize quality of life and comfort-focused care as his disease progresses. The patient's key laboratory values demonstrate severe renal failure, with a serum creatinine of 8.2 mg per deciliter and a BUN of 112 mg per deciliter, indicating marked uremia. His GFR is 8 ml per minute and creatinine clearance is 9 cc per minute, both consistent with end-stage renal impairment. Additional abnormalities include potassium of 6.8 meq/L, hemoglobin of 7.8 grams per deciliter, and evidence of severe metabolic acidosis on ABG, all of which further support the presence of advanced, life-limiting renal disease. The patient is exhibiting multiple hallmark symptoms of advanced uremia, including severe nausea and vomiting with intake falling to less than 25% of meals, along with confusion and lethargy reflecting worsening toxin buildup. He also has intense pruritus with excoriations and visible uremic frost, both classic signs of profound renal failure. Cardiovascular involvement is evident through a pericardial friction rub consistent with uremic pericarditis, and kidney output has declined to less than 200 cc in 24 hours, indicating severe oliguria. Together, these findings demonstrate advanced, symptomatic uremia consistent with end-stage renal disease. The patient is experiencing multiple serious complications of end-stage renal failure, including intractable fluid overload, having gained 18 pounds of fluid in just 2 weeks despite IV furosemide. He has developed pulmonary edema requiring oxygen and exhibits 3+ peripheral edema extending to the mid-thigh, reflecting severe volume retention. His hyperkalemia persists at 6.8 despite treatment, and he continues to have metabolic acidosis requiring bicarbonate therapy. In addition, severe anemia is contributing to marked weakness and fatigue. Together, these complications indicate profound, treatment-resistant renal decompensation. The patient's prognosis is further worsened by multiple comorbidities, including long-standing diabetes complicated by retinopathy and neuropathy, congestive heart failure with an ejection fraction of 25%, and significant coronary artery disease status post-CABG. He also has a history of cerebrovascular accident with residual weakness, all of which compound his overall decline. Together, these serious chronic conditions contribute to a markedly poor prognosis and reinforce the severity of his end-stage renal disease. The patient's functional status reflects profound decline, with a PPS of 30%, leaving him bedbound and totally dependent for all activities of daily living. He is unable to ambulate due to severe weakness and fluid overload, and his nutritional intake has fallen to less than 25% because of persistent nausea. This level of impairment demonstrates advanced functional deterioration consistent with end-stage renal disease. The patient meets Medicare LCD criteria for end-stage renal disease because he has made an informed decision to decline dialysis, and his labs confirm advanced renal failure with a creatinine clearance of 9 cc per minute, below the less than 15 threshold for diabetics, and a serum creatinine of 8.2 mg per deciliter, above the greater than 6.0 diabetic threshold. Clinically, he demonstrates severe uremia, oliguria with less than 200 cc of urine in 24 hours, persistent hyperkalemia at 6.8 despite treatment, and uremic pericarditis, all indicating profound toxin buildup and organ involvement. His condition is further complicated by intractable fluid overload with pulmonary edema, and his multiple comorbidities significantly worsen his overall prognosis. Together, these findings clearly establish eligibility under the LCD criteria for renal disease. Best practice documentation should clearly state the patient's informed decision to decline dialysis, include both creatinine clearance and serum creatinine to demonstrate end-stage renal impairment, and thoroughly describe uremia symptoms to show clinical severity. It should also note oliguria with the actual 24-hour urine output, document fluid overload, pulmonary edema, and the degree of peripheral edema, and list all comorbidities that worsen prognosis. Finally, the record must capture the patient's functional decline, including a PPS of 30%, bedbound status, and total dependence for all ADLs, to fully support hospice eligibility. To meet renal hospice criteria, documentation must show the patient declined dialysis, with labs confirming end-stage renal failure, creatinine clearance below 15 for diabetics and serum creatinine above 6. It should describe uremia, oliguria, hyperkalemia, and fluid overload, note comorbidities worsening prognosis, and capture functional decline like PPS 30% and total dependence. Missing these details weakens eligibility documentation.